Hello everyone. Hello everyone. Welcome to this ENT session of the past year's questions for FMGE exams. In total, I've included 25 questions from the past few years, and very quickly I'll tell you the answers and few explanations and finish that off very quickly. So the subject is ENT, the topic is past year's questions, and this is me. So question number 1, it says a child having dyspnea and stridor on supine position while feeding, the laryngoscopy is shown. Which phase of breathing will this stridor be? So what do you think the answer is? First of all, A, can you tell me the diagnosis? B, can you tell me the finding that is in the image? And C, can you answer the question? Now, this finding is a very popular finding. It's called omega-shaped epiglottis. I'm sure everybody knows this very popular image, omega-shaped epiglottis, and the diagnosis is laryngomalacia. In laryngomalacia, which is a congenital disease of the larynx, very typically there is omega-shaped epiglottis, and the stridor happens mainly in supine position and while feeding. But the stridor is usually inspiratory. So A is the correct answer, inspiratory stridor. Now larynx has three parts. There is supraglottis, so there is glottis, and there is subglottis. Now depending on which part of the larynx has a problem, the different phase of the breathing will have stridor. If supraglottic problem causes stridor, it is inspiratory stridor, inspiratory, and these two, that is glottic and subglottic problems, will either cause biphasic means during expiration as well as inhalation, or expiratory. Now as we have already seen that laryngomalacia is an epiglottic problem, there is an omega-shaped epiglottis, and epiglottis belongs to the supraglottis. So this is a supraglottic problem, and that's why it will have inspiratory stridor. That's it. Second question, very straightforward question, that McGovern's nipple is used in which condition? It's also called Magg technique. Is it used for bilateral chondroplasia, unilateral nasal blockade, obstructive sleep apnea syndrome, or pediatric maneuver for milk? Now, Magg technique is a technique used for bilateral chondroplasia. It's a life-saving technique. In bilateral chondroplasia, the patient's life is in danger, and so we have to do something very quickly and save the life of the child by doing this maneuver called Magg technique. So what is done in this technique? This kind of a feeding bottle nipple, if you can see that this thing is a feeding bottle nipple. That's why there is Magg nipple technique. A big hole is made in the nipple, which you cannot see in this particular image, and this is put into the child's mouth. And then with this tape, as you can see this tape, it is taped around the face so that it cannot come out. So chondroplasia, I'm sure you know, when the choana is completely blocked. What is choana? So when I draw the face like this, let me use black color. So when I use the face, draw the face like this of anybody. Now this is the nose, and behind the nose, this area is the nasopharynx, NP. Nasopharynx. The boundary between the nose, this boundary between the nose and the nasopharynx, this boundary is called choana. So choana is a boundary between the nose and the nasopharynx, and the air that we breathe from the nose goes to the nasopharynx through the choana. So normally in all of us, the choana is open boundary. That's why the air can go from there. If a child is born with blocked choana like this, if the choana is blocked, then it becomes choanal atresia. And if it is in both the sides, right side and left side, both the nose is blocked, then the child cannot breathe from the nose, and it's a life-threatening condition. So we have to do something which is life-saving, and for that we do this technique called McGovern's nipple technique. Okay. Now again, it's a very straightforward question. It's a 12-year-old child having swelling in the oral cavity just below the tongue, as you can see in the image. On examination, it's a brilliant translucent blue dome-shaped structure. Confirm the diagnosis. So even if I don't give you this history, if I just give you the image straight away and I ask you what is the diagnosis, it's a spot diagnosis, guys, where this is a ranula. Ranula is a cyst of sublingual gland. It's a cyst of sublingual gland. And because sublingual gland is present below the floor of the mouth, this area is called the floor of the mouth because the lingual gland is present in the floor of the mouth. So the swelling of the sublingual gland, the cyst of the sublingual gland, will also be present in the floor of the mouth. Very two important things here. A, it is always unilateral. As you can see in the image, it does not cross the midline usually unless it becomes too big. And B, the capsule is bluish in color, which is also given in the question, blue because the capsule is bluish in color. And the treatment is another very important MCQ for ranula. Marsupialization is the answer. What do you do for ranula? Marsupialization. Just remember this. Okay. And Stenson's duct is a duct of submandibular gland. In Stenson's duct, swelling is uncommon. It is usually stone. Stone is called silolithiasis is called stone in the submandibular gland. And hygromas cysts are usually seen outside, not in the mouth. Usually they are seen outside on the face, on the neck, and all that areas. Okay. Question number 4. Caloric test, which is a vestibulo-ocular reflex, usually is done for all of the given except. So, in which of the following is a caloric test done? 3 are correct answer. One of the following is a situation where caloric test is not done. And caloric test is a type of vestibulo-ocular reflex. It means vestibule is a part of the labyrinth in the inner ear, vestibular, and ocular is eye. So, there is a connection between the vestibule and the eye. And when you stimulate the vestibule, through that connection, the eye begins to move left-right, and that left-right movement of the eye is called nystagmus. So this vestibulocochlear reflex is the cause of nystagmus when the vestibule is stimulated. So when you stimulate the vestibule, if the patient begins to have nystagmus, that means the vestibule is getting stimulated. If there is a vestibular disease also, vestibulitis and things like that, again the same reflex is stimulated and the patient begins to have nystagmus. That's why I'm sure you know in vestibular diseases and vestibular stimulations, we always look at the nystagmus. So we are trying to actually stimulate the vestibulo-ocular reflex in all these cases. So which of the following conditions is a condition where vestibular reflex or caloric test is not indicated? Is it damage of the vestibular nerve? If the word is vestibule, then obviously you have to do this test. Then side-to-side nystagmus is true. As I told you, when you stimulate the caloric test, the patient begins to have side-to-side nystagmus. That is also true. Vestibular neuronitis, again the word vestibular is there. So because it is a vestibular ocular reflex, from this name we can know that this must be one of the conditions where you do this test. This must be one of the conditions where you do. The name of the disease has this word vestibular, and nystagmus we all know is what we see during a caloric test. It's a very common knowledge. And ninth nerve has nothing to do with reflex. Ninth nerve does not supply the inner ear. Ninth nerve has nothing to do with this reflex. So ninth nerve does not supply the eye also, and that's why damage to the glossopharyngeal nerve, which is ninth nerve, has nothing to do with vestibulo-ocular reflex. Very simple, straightforward question again. Then we go to question number 5, and the following image shown X-ray view. So what X-ray view is done? As you can see, it is almost antero-posterior view. Can you see antero-posterior view? You can see the rays are passing straight almost, and it is going through this just below the occiput straight almost. So what view is being done? Is it Waters view, Cardwell's view, Towns view, or Hitz view? Now Hitz view, let me take this image sideways so that I can write. Hitz view is a lateral view. It is taken from side, and this is not a side view. It is done for ethmoidal sinus. Usually, it has other indication also from the ENT point of view. It is done for ethmoidal sinus. Then Waters view is AP view, but 45-degree angle. In Waters view, we take an angle of 45 degree, and that's why this is almost 0-degree angle. It's not 0 degree. If you can see, the head is turned like this. Horizontal will be like this. There is an angle here, and roughly it is, you can make out it is 30-35-degree angle, and this is done in Towns view. So the answer is Towns view. In Towns view, the angle from AP is around 30 degree. In Cardwell's view, the angle is between 5 to 15 degrees angle, right? So if you can make out, this is the horizontal plane in this person, and the rays which are passing is slightly angled. Neither it is very little like 5-10 degrees as is in Cardwell's view, nor is it too much like it in Waters' view. And so this is a Townes view. Townes view otherwise is very uncommonly asked from the ENT point of view. I think in radiology Townes view might be important, but from the ENT point of view, Townes view is not a very common view that we do generally. It is done to compare two mastoid because it is done from the front and the angle is 30 degree. You can see both the mastoid, right and left side. And so usually in ENT we do Townes view to compare the right mastoid with the left mastoid. That's what we do. So this is a Townes view. But these X-ray views of ENT, Waters' view, Pierre's view, Cardwell's view are the most important X-ray views that they ask you from the ENT point of view. Townes view, like I told you, is less commonly asked, but this was one moment, one exam that they'd asked about this Townes view. And you know how to identify. And this is how the X-ray of the Townes view will look like. So this is a typical Townes view X-ray where you can see this mastoid and this mastoid. And so you can compare the two sides because they are done for mastoiditis, and mastoiditis is a unilateral disease usually. One side is affected, one is not affected. So you can compare them easily. Also, additionally, you can see many other things in Townes view, like this arrow, as you can see, is showing the styloid process. So Townes view has an additional advantage. It can show the styloid process, and with the styloid process enlarged, a disease called Eagle's disease that also can be diagnosed with Townes view. Then you can see the opening of the foramen magnum also, and through the foramen magnum you can see the other things like the base of the sella bone, which is a part of the sphenoid bone, and to some extent you can see this frontal sinus also. But for frontal sinus, Cardwell's view is the best view. Townes view is not that good. Cardwell's is the best view. That I'm sure you know already. Okay, so Townes view, remember that. Then type of stridor in croup. Now you can, even if you don't know this, you should be able to answer this by now, because I just told you that we divide I'll repeat what I told you. We divide the larynx into three parts: glottis, supraglottis, subglottis. And depending on which part of the larynx has a problem causing stridor, it can be either inspiratory or expiratory or biphagic stridor. Now, croup is also called laryngotracheobronchitis. So, as the name tells you, larynx, trachea, and bronchus, all the three are inflamed at the same time. Now, I'm sure we all know trachea and bronchus, they lie in the below the larynx, so they are related to the subglottis. And everybody knows it's a very common thing that in laryngomalacia, in croup, which is laryngotracheobronchitis, there is a very important X-ray finding which is called steeple sign. Now, you know what is steeple sign actually? This name is very popular. I'm sure you know this name. It's a very, very popular name. But what is this sign? Steeple sign, where there is a narrowing of subglottis. So the subglottis becomes very, very narrow. So this is a subglottic and below the subglottis problem. And I told you already, if the subglottis is problem causing stridor, what kind of stridor it is going to be? Either biphagic or expiratory stridor. So B is a correct answer and C is also a correct answer, biphagic as well as expiratory. But when both are given, which is a better answer? If it is a glottic disease and you have to pick one answer out of the two, you go for biphagic. But if it is a subglottic problem and you have to pick one of them, then you should go for expiratory stridor. So in this case, out of these two, both of which are correct answer, we will go for expiratory stridor as a better answer, because it's subglottic, predominantly a subglottic problem. Once again, if it's a glottic problem, biphagic is a better answer out of the two. But in supraglottic problem like laryngomalacia that we discussed, there is no doubt at all, inspiratory will be the correct answer. Now, in croup, you have to know one or two other points, like it is caused by who? Croup is caused by, anybody who knows the answer? Let's see. It's caused by a virus called parainfluenza virus. And the other steeple sign is a very important MCQ, very important MCQ. The other thing in croup related to treatment, in croup we do two common things. We give steroid to every child of croup, and we also do nebulization, usually epinephrine, or you can say adrenaline, and we add antibiotics to prevent the secondary infection, that is a secondary treatment. So these are the important points about croup, and it's a very popular question actually for you. Okay, another question. A 22-year-old male with recurrent nasal bleeding with the following sign is shown in CT scan. So all are false except, so 3 are true, all are false. Now first of all, you have to make a diagnosis. If they tell you a male child with recurrent bleeding, the first thing that comes to your mind is juvenile nasopharyngeal angiofibroma. The word male is very important because angiofibroma is seen only in males. At least theoretically it is never seen in females, and it is seen in a juvenile age group. Juvenile age group can be up to 18 years. But the tumor may start at around 18 years, 10, 12, 13, 14, around that age, at juvenile age group. But often it presents a bit late. When the tumor becomes big, that is when the patient begins to have problems like epistaxis is the most common thing. So this first line will tell you it must be juvenile nasopharyngeal angiofibroma. But in this particular case, the CT scan can be additional thing. Now this is CT scan is a sagittal view of the paranasal sinuses. Sagittal view. Now before this we have been, as I showed you, the X-ray, which was AP view. This is a CT scan upside view. And in this CT scan, I'm sure you know this is maxilla, M for maxillary sinus. Orbit we can identify everybody. This is the cranial cavity, this area is the cranial cavity. So I don't have to tell you these very simple things. Most of us know this. And if you look at this maxilla, this is the posterior wall of the maxilla, which should have been like this. It has been pushed anteriorly because there is a tumor here. And this tumor is angiofibroma. Right. Now this finding on a CT scan, the posterior wall of the maxilla is pushed anteriorly, this is called antral sign. In angiofibroma, out of the two very popular question, one they ask you this question, 18-year-old male child having recurrent epistaxis, what is the likely cause? 18-year-old male child having recurrent epistaxis, likely cause is angiofibroma. That is a very popular question, very simple question. The second question they ask you very commonly is about this sign called antral sign. And this image is showing you antral sign. Antral sign is also called Hallman-Miller sign. Now about antral sign, guys, you have to know two things. What are the two things you have to know? A, you have to know that this sign is seen in angiofibroma, easy. And what is the finding of antral sign? The posterior wall of the maxilla is pushed anteriorly, and the CT scan could be important. This CT scan, I'll show you other CT scans also about this sign. Right. Now, the question they are asking you basically that in this patient, what is not the true factor? Which of the following is not true about angiofibroma? That there is an outgrowth of blood supply, it's a vascular tumor. So this can be true. There is outgrowth of blood supply. The tumor vessels lacks contractility. It cannot contract. The blood vessel of the tumor cannot contract. That is also true. That's why the bleeding is recurrent and severe, because in the tumor's blood vessel, the middle layer is absent. In blood vessels, any blood vessel in the body, there are 3 layers. And the middle layer is called the contractile layer. It is made up of fibrous tissue, also called muscular tissue. And it causes the contraction of the blood vessels. Whenever the bleeding happens due to anything, the first thing that tries to stop the bleeding is that contraction. It's called vasoconstriction. Tries to stop the bleeding. In this patient, in the patient of angiofibroma, because the blood vessel of the tumor does not have the contractile layer, the middle layer, it cannot go into contraction and the bleeding cannot stop easily. So that's what it's trying to tell you. It's a very important point. And third point is that because a vascular tumor, the blood vessel of the adjoining area also invades the tissue and causes more vascularity. So this is also true. And it lacks the capsule is not true. It is called encapsulated tumor. That means glomus tumor, this angiofibroma is described as encapsulated tumor. That means it has a capsule around it. So that is not true. Okay. So, but in angiofibroma, the two most important things you have to know, they give you the history, a male child with epistaxis, what is the likely diagnosis? angiofibroma, and above antral sign, which is hormonal sign, the finding and the CT scan. Now I'll show you two more CT scan of antral sign. Look at this. This is a normal, see, this is a axial view of the CT scan. This is maxilla of one side, and this is the maxilla of the other side, and that red thing is a tumor behind the maxilla. You see this gap, can you see this gap? From here it is entered inside, this tumor is entered from here, and subsequently what will do, it will do this, it will cause a finding like this. See, the tumor is expanded and push the posterior of the maxilla anterior like this. So this is how antral sign happens. Just try to show you antral sign. Okay. Now recently they've been asking question from audiometry very commonly. So this is audiogram, and two or three things about audiogram that you have to know. If they show you audiogram, they may ask you questions like, is there hearing loss or not? HL is hearing loss or not is one thing. Second thing is type of hearing loss. Type means, is it CHL or SNHL or mixed loss? And the third thing they may ask is the cause of this audio diagnosis. What is the cause of hearing loss? In this question, particular question, look at the question. This is an audiogram of a 30-year-old pregnant lady with conductive hearing loss. Diagnosis. So they've asked this question. Okay. Now, and the choices given are otosclerosis, Meniere's disease, noise-induced hearing loss, and presbyacousis. Now, even if the audiogram is not given, suppose the audiogram is not given, still in most cases this question can give you the diagnosis. If a pregnant lady around 30 years has conductive hearing loss, most likely is otosclerosis. This is a very, very typical history of a patient with otosclerosis. This lady is around 30-35 years old roughly. She is usually pregnant during pregnancy, and it's conductive hearing loss because conductive hearing loss happens in middle ear disease. So it must be a middle ear disease, that's why it's a conductive hearing loss. Okay. So most likely it is otosclerosis. Now if you look at the audiogram, then you can see this BC audiogram, this is a BC graph, has a sudden dip at 2000 Hz frequency. This finding in audiogram where there is a sudden dip at 2000 Hz frequency, this is called Cahart's notch. So this audiogram is showing you Cahart's notch, and Cahart's notch is again a finding of otosclerosis. So the history is telling you to otosclerosis, and the image is also telling you to otosclerosis. Therefore, otosclerosis is the correct answer. Now, Meniere's disease is usually seen in males, okay, and the patient has sensory neural hearing loss. Actually, all of them, they have sensory neural hearing loss. So even if, even if in this case, if they give me a patient with conductive hearing loss and they give me these four choices, the only possibility of conductive hearing loss out of these four choices is otosclerosis. The only one which can have conductive hearing loss, the rest of them can only have SNHL. So it's a very simple question actually. Additionally, they have told you it's a pregnant lady. It is more in favor of otosclerosis. So we know the diagnosis also, that the cause of otosclerosis is a very typical patient in otosclerosis, and the image is also adding to all this. So this was one of the simplest questions that you can get in the ENT exam. But when you look at this audiogram, I told you that few things that you should be able to diagnose with an audiogram. A, the hearing loss is there or not. So what do you do when you get an audiogram like this? The first thing is identify 20 and 30 decibel, and between the two will be 25 decibel obviously. So draw a line here. Draw a line here 25 decibel. And see if there is any graph below this line or not. Like in this case, there is a graph here below the line. If there is a graph below this line, then there is a hearing loss. If there is no graph below this line, there is no hearing loss. In normal hearing, the graph cannot come below 25 Hertz. Okay, that is the easiest thing to remember in graphs, that hearing loss is there or not. You can make out from there. Then there's some special audiograms. Like, what is the specialty of this audiogram? There is a hearing loss. We know this because there is a graph below the 25 mark, and there is a dip at 2000 Hertz, which is called Cahart's notch. And Cahart's notch is telling you is giving the diagnosis. It is telling you it is otosclerosis. Okay, so sometimes the audiogram may have this kind of a special finding by virtue of which we can make diagnosis like in this case. So guys and girls, this was a very simple question. I'm sure everybody knew the answer. Let's go to the next question, question number 9. A teacher presented with hoarseness of voice. Laryngoscopic image is shown in this one, and they ask you to identify the pathology. Now, if a teacher has a hoarseness of voice, it tells you it's a vocal cord disease. It has to be vocal cord disease because in teachers and singers, there is a misuse of voice and vocal cord. And the two most common disease that happens in teachers and singers due to misuse of voice, one is vocal cord nodule and the other is vocal cord polyp. These are the two common diseases. Okay, and so it has to be one of these. So it is either A or C. Rhinitis edema is seen in usually talkative females. It is seen in talkative females. It is uncommon in teachers and singers. And keratosis is like a chronic laryngitis. It's like pre-malignant situation of the vocal cord. It is seen in smoker and elderly males. It's a type of chronic laryngitis, you can say, keratosis of the larynx. Okay, it has nothing to do with teaching profession and misuse of voice. So these two are unlikely in this patient. Now, so is it nodular polyp? That you will know by looking at the image. So nodule, vocal cord, nodule and vocal cord polyp. The history is very similar in both of them. History we know already that both are seen in people who misuse the voice chronically, like teachers and singers, which I told you already. Now, when you look at the image which is shown here, nodule is bilateral, it is small, and it is whitish in color. Polyp is usually unilateral, bigger, and it is usually red in color. So if you know this difference between nodule and polyp, how the look of the nodule is and how the look of the polyp is, my dear friends, you can make a diagnosis now. Now look at the image, you can see at the arrow is also showing there is a very small swelling, very tiny swelling you can make out. It's bilateral. So small bilateral swelling on both the vocal cords is more likely to be nodule. So this is a vocal cord nodule. The image telling me if it is polyp, it is much bigger. It will be red in color. It will be on one side only. This one is both sides, very tiny, small. And the common thing between nodule and polyp is the site is the same. Both nodule and polyp is seen what is called at the junction of anterior 1/3 and posterior 2/3 of vocal cord. So look at this vocal cord. Vocal cord in this particular diagram image is from here till here. This is much is the vocal cord. Now, if I divide the vocal cord into three equal parts like this, 1/3, 1/3, 1/3, then this point is the junction of anterior 1/3 and posterior 2/3. And see, nodule is seen here at this junction of anterior 1/3, posterior 2/3. Polyp is also here. So this is common thing between nodule and polyp. They are both seen at the same site on the vocal cord, but the treatment is different. The main treatment of choice in case of nodule is voice rest. Voice rest plus minus we give proton pump inhibitors also. If this fails, then we may have to do surgery. Surgery is secondary option, not the first line of treatment in case of nodule. Whereas in polyp, the treatment of choice is a surgery plus minus voice rest. So first, voice rest is not very important, but here also we might add proton pump inhibitors because both nodule and polyp is very commonly seen in people who have some kind of regurgitation problems, regurgitation of the acids from the stomach and the esophagus. So to control that part, we give proton pump inhibitors in both of them. So what I told you now in this slide is everything that you have to know about nodule and polyp If you know these points about nodule and polyp, and if you can identify the nodule, I'm sure you can answer any other question they ask you from this particular point. So guys and girls, please remember this very simple topic, very popular topic. But in the meanwhile, we go to next question, question number 10. Now, diabetic with ear pain has HbA1c of 10, that means it's a chronic diabetic. The glucose, hemoglobin glucose level is very, very high, and there is gestational ear pain with blood stains discharge. Most likely diagnosis. Now, if a diabetic has chronic diabetic, as the finding is telling you, has a severe ear pain with blood ear discharge, that means in diabetes usually it is a opportunistic infections. We all know if the person is diabetes, the immunity of the patient is compromised, and the pathogens which are opportunistic, they try to infect this area. So in this case, because it's a ear pain, so it must be ear infection. That's very, very logical. Now in diabetes, ear infections, two very common ear infections. One is malignant otitis externa. Malignant otitis externa is typically seen in diabetic. Also common is otomycosis, right? Otomycosis, which is a fungal infection of the ear. Now common otitis externa, like acute otitis externa, diffuse otitis externa, is uncommon in diabetic, but pain can be significant in this patient. So this is unlikely diagnosis. Possibility is there. Malignant otitis externa is a very, very likely diagnosis. Serous otitis media is the least likely diagnosis. This cannot happen. Serous otitis media is a middle infection. It is seen in children, not in adult. So people are not diabetic. Children, small children are not diabetic. It has nothing to do with diabetes. And in serous otitis media, there is no pain. So this patient has no diabetes mellitus, and no pain. Right. Now this is the only diagnosis that is completely ruled out in this particular case. This cannot be possible. But if a diabetic, chronic diabetic, has severe ear pain, the rest of the three are possible. Now out of the three, we have to pick one answer. This is the least likely out of the three. So now we are left with the malignant otitis externa and otomycosis. Otomycosis causes usually ear bleed is less common because it's not a very, very invasive disease, but malignant otitis externa is a highly invasive disease. It causes osteitis. It infects the bone and infection of the bone. So bleeding is more likely. So it's a very tight diagnosis between malignant otitis externa and otomycosis, but with this history, we usually go for malignant otitis externa. Now, let me give you a trick here. If there is an external ear inflammatory disease, and if you have a doubt, and the choice, one of the choices is malignant otitis externa, but you have a doubt, is it of the diagnosis? You know, there are 4 diagnoses given, and you are not very sure, go with malignant otitis externa, because 9 out of 10 times when they ask you question from external ear, they only ask you malignant otitis externa. So in the class also, I always say you don't spend your time reading external ear inflammations, because the only inflammation you read in external ear is malignant otitis externa. You can look at the history of the last 10 years paper, not only MCI screening test. Look at the NEET PG exam, look at the AIMS, the INISET exam. They have never asked, in the last 10 years, they have never asked any other question except malignant otitis externa from the external ear. But malignant otitis externa, if you put all the question paper together, has been asked at least 3 to 4 times in the last 10 years. So that's why I say, if there's an external ear disease and you have confusion in making diagnosis, you're not very sure, go for malignant otitis externa. 9 out of 10 times is going to be a correct answer. You can take that kind of a risk. Okay. Now, malignant otitis externa, usually when we ask a question, this is the type of history. They'll say you have diabetes with severe pain, maybe discharge also, and they'll ask you one of the 4 questions. The history is very similar to the one that is given in the question. Either they will ask you diagnosis, which was this question, or they'll ask you the most common investigation done, or they'll ask you the drug of choice, or they'll ask you the most common complication. They ask you only one of these 4 questions. So it's very, very, you can predict what is the question going to be if they ask you that. So diagnosis we know from the history. Now investigation, most common investigation we do is CT scan, contrast analysis scan, but this is not the best thing. The best investigation is technetium 99 scintigraphy. This is the best one out of the lot. Now, drug of choice is another very popular question from malignant medicine. And because of bacterial infection, we have to give antibiotic. 3rd generation cephalosporins. Now, I don't have to tell you that we have to give anti-diabetics also, because diabetes patient, you have to control the diabetes. It's a chronic diabetes. And most common complication, I told you already, is osteitis. Here, I told you, here, osteitis is the most common complication. So these are the type of questions they ask you about malignant nephritis. It's a very predictable topic. When they ask you a question from this topic, you can almost always predict what the question is going to be like. It's very simple in that sense. Now next question, question number 11. A patient presented with foul smell from the nose, anosmia and nasal obstruction. There is foul smell, there is anosmia, loss of sense of smell. Anosmia, I'm sure you know, is a loss of sense of smell, and nasal obstruction. So when I tell you there is a foul smell from the nose with nasal blockade and loss of sense of smell, most people can make a diagnosis by this. Foul smell and anosmia very commonly together are seen in atrophic rhinitis. So most likely from the first line I can tell you it is atrophic rhinitis, but in this particular question we are given an image to help you aid. So what you see in the image is this greenish blackish discharge. Green black collection in the nasal cavity. This green black collection in the nasal cavity is called crust. Now crust is the one that occupies the nose, it blocks the nose and causes nasal block. This may cause anosmia, loss of sense of smell because it's blocking the nose. Now anosmia can be due to atrophy of the nerve also, but this can cause anosmia, and this gets infected and causes foul smell. So lot of problem of atrophic rhinitis is due to the crust that collects in the nose, which is shown in the image. So this is atrophic rhinitis straight away, right? In rhinitis sicca, sicca means dry. The word sicca means dry. There is dryness inside the nasal cavity. There is no foul smell usually. There is no smell and there is no anosmia. Loss of sense of smell. You understand that loss of sense of smell will only happen either the nose is completely blocked, the air is not entering the olfactory epithelium, or if the olfactory epithelium is atrophied, as in atrophic rhinitis, it can go into atrophy. Rhinitis medicamentosa is rhinitis due to excess use of medicines, vasoconstrictors like xylometazoline, oxymetazoline and all that. And in this particular case, there is no history of medical use or nasal drop use. Plus, this patient will also have no foul smell. Foul smell will not be there. There will be no obstruction also. Nasal block will not be there. So it is not matching. And allergic rhinitis, we all know, is a very, very different kind of. It's an allergy. In allergy, you have itching, sneezing, watery of the nose, all that. It is nothing. There is no foul smell. There is no anosmia and all that. Allergy is a very, very different kind of a presentation. It can be ruled out. So this is atrophic rhinitis, very commonly asked in the exam. Now, out of all the types of rhinitis, I'm sure you know that rhinosinusitis, rhinitis and sinusitis is one of the very important topics from nose and sinuses. And out of all the type of rhinosinusitis possible, the most commonly asked rhinosinusitis is atrophic rhinitis. So I always suggest that when you are revising nose for your exams, and suppose you don't have too much time to devote to the nose and sinuses, when it comes to the topic of rhinosinusitis, you can skip all of the rhinosinusitis but read atrophic rhinitis properly, because this is the most popular one they ask in the exam out of all the rhinosinusitis. And what are the 3 or 4 points which are very, very important? Atrophic rhinitis. So atrophic rhinitis I'll tell you guys 3 or 4 important points that you need to remember. One is the other name. It is also called OGA. And what are the features? Features I've already told you. There's roomy cavity, there's crust formation, with this foul smelling, anosmia. These are the features of atrophic rhinitis, which I'll not tell you. There's a very important feature called merciful anosmia. Just the name. Remember, they ask you merciful anosmia is a feature of which disease? So remember, merciful anosmia is a feature of atrophic rhinitis. And there is something in the treatment, we use something called alkaline nasal douche. Douche is a Russian word. So those who have done MBBS in Russia or CIS countries will know douche means shower, nahana, cleaning of the nose from inside with alkaline solution. And the content of the alkaline solution is also sometimes an MCQ. It has 3 sodium salts. One is sodium bicarbonate, the other is sodium biborate, and the third one is sodium chloride. So when you mix these 3 salts of sodium in water, it becomes alkaline nasal solution, and with that if you clean the nose regularly, it becomes alkaline nasal douche, which is done for atrophic rhinitis. So these are some of the important points about atrophic rhinitis that you should remember from the example. Very, very important. Okay. And then we go to question number 12. While performing a caloric test, which type of nystagmus would you expect on cold ear irrigation? Now, one question about caloric test we had mentioned before. Remember, caloric test I told you is a vestibulo-ocular reflex, and I told you look a few points then. And there's another question from the same topic, caloric test, in different exam, in different year. So what it's telling you is caloric test is an important test for you. You have to know caloric test nicely. Now, caloric test nystagmus is not an easy topic. It's a very complex and difficult topic. But fortunately, in your exam, they don't ask you very difficult questions. So you should know that when you do caloric test, as I told you in the previous question, one of the previous questions, you are actually checking the vestibular function. It's a type of vestibular function test. It's a type of vestibular function test, and it is checking the vestibulo-ocular reflex that I told you. That's why when you stimulate the vestibule in caloric test by syringing the water, this vestibulo-ocular reflex is stimulated and the eye starts moving left and right, and that's called nystagmus. Right? So when you do a caloric test, nystagmus is always horizontal, never vertical. Vertical nystagmus when the eyeball moves up and down. Now, vertical nystagmus happens usually due to cerebellar problem. Usually. Cerebellar is a brain stem, part of the brain stem. Cerebellar is related to the brain stem. So, cerebellar diseases will cause vertical nystagmus, if at all. And if the vestibular disease causes vertical nystagmus, it is either the posterior canal or superior canal. These 2 canals can cause the vertical nystagmus. The horizontal canal, caloric test stimulates the horizontal canal. It cannot stimulate the vertical canal. It cannot stimulate the posterior canal. And horizontal canal can only cause horizontal nystagmus. Horizontal canal, horizontal nystagmus. So caloric test can only cause horizontal nystagmus. So if you know this point, straight away C and D is ruled out. Caloric test cannot cause vertical nystagmus. Okay. Now comes the answer that will the nystagmus be to the same side or opposite side when you syringe with cold water? And this I think everybody knows. The mnemonics calls COWS, which is given in every ENT book. Every book has this mnemonic, where C stands for cold water, which is 30 degree usually, and O stands for opposite side. So with cold water, the nystagmus will happen to the opposite side to the ear that you syringe, and W stands for warm water, which is 44 degree, and S stands for same side. So with cold water opposite side, warm water same side, and because it's cold water, it will go to which side? Opposite side, isn't it? So B is the correct answer. I think most of you know this already. It's a very simple question, very straightforward. It's very, very popular question. Information actually, which everybody knows. Calorie test. But once again, because we have discussed 2 questions in calorie test already, that means it's a very, very important topic. Now, a 6-year-old child presented with emergency department complaints of bleeding from the nose, epistaxis. Which of the following arteries the most commonly affected? So basically, which is the artery of epistaxis? Which is the artery of epistaxis? They are asking you which is the most common artery that bleeds during epistaxis. And it's a very straightforward question. There is no discussion here. Sphenopalatine artery. It bleeds from what is called Little's area. Little's area has a plexus called Kisselbeck's plexus. This is a very, very popular thing. We all know about Kisselbeck's plexus, which is in the Little's area. And it is formed of 4 arteries, but out of the 4 arteries, sphenopalatine artery is the main artery that participates in the Kisselbeck plexus, and therefore it is the most common thing that bleeds. Epistaxis. Now this is an image showing you the Kisselbeck's plexus. This circle shown here is a Kisselbeck's plexus, which is formed by 4 arteries. You see the 4 arteries that comes and form the Kisselbeck plexus. One is this artery, which is going like this, anterior nodal artery. One is this artery, septal branch of the sphenopalatine artery. This is the answer in that question. The third is this artery, septal branch of the greater palatine artery, and one is this artery, septal branch of the superior labial artery. So the other thing you have to remember, which are the 4 arteries that participates in the formation of Kisselbeck's plexus, and these are the 4 arteries that participate in the formation of Kisselbeck's plexus. So all of them can cause epistaxis from the Little's area, but mainly this one. This is the correct answer in most cases. Okay, this is called the artery of epistaxis. It's a straightforward question. Okay, a 12-year-old male presented with nasal obstruction. On examination, there was a mass protruding from the choana. What is a possible diagnosis? Conval cyst, endochoanal polyp, hypertrophic rhinitis, and adenoid hypertrophy. Now suppose you don't know the answer. Okay, so it's a very simple question. Suppose, see, there's a word choana here and there's a word choana here. The word is matching. So this should be the likely diagnosis, answer. And this is actually the correct answer. Endochoanal polyp is the other name for maxillary polyp. Maxillary polyp, one second. Maxillary polyp starts in the maxilla and goes out through choana. Okay. So I decreased the audio. I think audio was having some problem. So try to decrease the audio. Please give the feedback to the team if there is still a problem. I think this should be better now. Hello. Okay. So coming back to the question, endochoanal polyp is the other name for maxillary polyp. It starts in the maxilla and protrudes outside the choana. That's why it's called endochoanal polyp. Now, adenoid is present in the nasopharynx, and Thornwald cyst is also present in the nasopharynx. And therefore, they will not protrude out of the choana, but both can be seen in children. In hypertrophic rhinitis, nothing protrudes. There may be hypertrophy of inferior turbinate, and it will never protrude. Right? Now, all these 4 diseases are possible in children, but typically at 12 years of age, endochoanal polyp is very, very common. In child with growth near choana. I told you choana, Quena is the posterior end of the nose. If a child has a growth, child means 12-year-old child, 8, 9, 10 years, 12-year-old child, there are two possibilities. One is juvenile nasopharyngeal angiofibroma that we discussed one of the questions, and AC polyp. What is AC polyp? Antroconal polyp, the one that we are discussing right now. So if there is a growth in the quena, protruding to the quena, these are the two likely diagnoses, especially if it is a child. Okay, this is 100% for you. A child having quena problem, growth in the quena, protruding to the quena, it is one of the two. Now this will bleed. There will always be a history of bleeding, and rest of the signs, enteral sign and all that you see. And this one never bleeds. Never bleeds. Okay. So that's a very important thing. In this particular question, there is no mention of bleeding. And that's why antroconal polyp is a likely diagnosis. Even otherwise, juvenile angiofibroma is not given in the choices. So it's straightforward answer. Okay, so keep this in mind. If a child has something or growth in the quena area, it is always one of the two. And if the history is bleeding, then go for JNA without thinking twice. And if there is no bleeding, go for polyp without thinking twice. 100% of the time it will be a correct answer. Now JNA, I already told you enteral sign and few other things. Antroconal polyp, as is seen in children, as I told you, and the treatment of antroconal polyp is antibiotics because it's caused due to infection, plus FESC surgery. FESC stands for functional endoscopic sinus surgery. So this surgery is also done in antroconal polyp, FESC surgery. Okay, it's pale in color. So we'll go to question number 15, which says a 30-year-old patient presented with difficulty in completely closure of the left eye, is not able to close the left eye, and experiences trouble while eating food. So the eating food is also having a problem. Which nerve is most likely to be damaged in this case? Now, is it greater auricular nerve, auriculotemporal nerve, facial nerve, or vagus nerve? What comes to your mind? I think it's a very straight. It was asked last year only. It's a very simple question, right? Now, greater auricular nerve is a purely mainly sensory nerve. See, both these problems, if you are not able to close the eye is closed due to muscles. So it's a motor nerve. It has to be a motor nerve. And when you are chewing the food, troubling in eating the food, that also chewing is used, and chewing is controlled by the masticator muscles. And so only sensory nerve cannot cause both the things together. And auriculotemporal nerve is also by and large the sensory nerve. And auriculotemporal, as the name says, it supplies the auricle, that is pinna and the canal, and the temporal area. This temporal area is this area of the face. It supplies this part. It is nothing. It is not supplying the eye. It is not supplying inside of the mouth, which is chewing. So these two are straightway out. And vagus nerve, we all know, does not supply the vagus goes down. It supplies the larynx and beyond below that. Vagus does not supply the eye. It has nothing to do with the eye. So if eye has a problem, vagus is already out. So the only nerve possible is the facial nerve. Facial nerve supplies, the name facial nerve comes from the word that supplies the muscles of the face. And both these functions are related to the muscle of the face. Eye is closed by the muscle of the face. So if the facial palsy happens on that side the eye is not able to close properly or completely. Eye always remains open when the patient is sleeping. Eye is like this. It is always open, and that's why it causes exposure keratitis also. The dryness in the eye happen because it's exposed. And because the buccal intermetal and these muscles are not moving, so the chewing is problem, and often when the patient is chewing, something comes out from this angle of the mouth. From here, it is drooling of saliva, and the food comes out from this area, because again this area, all these muscles are supplied by the facial nerve. So I think it's a straightforward question, facial nerve. Now facial nerve from the ENT point of view is the most important cranial nerve that they ask in the exam. Everything about facial nerve is very important. From the ENT point of view, you have to know about 4 branches of the facial nerve. Which are the 4 branches out of 7 branches of the facial nerve that you should know? One is greater superficial GSPN, as we call it, greater superficial petrosal nerve. This is a very popular nerve. This mainly controls lacrimation, tears in the eye. But This is not the only supply, it has other functions also, but this is the most popular function. Then you have to know nerve to stapedius. As the name tells you, it supplies the stapedius muscle, and therefore it controls acoustic reflex, because stapedius muscle is responsible for acoustic reflex, so it controls acoustic reflex. Chorda tympani is the most popular branch of facial nerve. It's like a puspa facial nerve. Puspa, most important, very very important. It supplies taste buds on the anterior tooth of the tongue, and also a few salivary glands, submandibular and sublingual salivary glands. And the last is pes anserinus. What is pes anserinus? Pes anserinus is the terminal branch of the facial. The last branch in the parotid gland, it again divides into 5 branches. And the family of 5 is called pes anserinus. And what do these 5 branches do? They supply almost all facial muscles. Not all of them, almost all facial muscles, plus platysma also, which is insignificant in our case. So these are the 4 branches of the facial nerve that you have to know properly about. So to read about these branches, they may ask you questions from here. Okay, very important now. But in the meanwhile, we'll go to the next question, question number 16. A patient arrives at the emergency department following roadside accident, inability to open the mouth, and maxillofacial trauma. So it's a very severe damage of the mouth and the face and the maxilla and all that. So which of the following is preferred to establish an emergency airway? So it's clearly telling you that the patient has a severe accident where the face is damaged and the patient is not able to breathe from the nose or from the mouth because of the damage of this structure. So you have to create an emergency airway, bypass this area and create an emergency airway. So which is the preferred site to establish the airway? Is it the cricothyroid membrane, cricohyoid membrane, cricotracheal membrane, or thyroid cartilage? Now, in this case, what is the best answer? The best answer is tracheostomy. Okay. So whenever there is an airway problem and you have to establish an alternate airway in an emergency, the best thing to do, if you cannot intubate, the best thing to do is intubate immediately. But if there is a maxillofacial trauma and the mouth cannot be opened, that's why there is the answer that mouth cannot be opened. To intubate, you have to open the mouth, and so you cannot do the intubation. So tracheostomy is the best thing, and tracheostomy is done in tracheal ring. It is done in tracheal rings, usually ring 2 and ring 3, but tracheal ring. The number is less important right now, but this is not given in the choices. Okay, so if this is given in the choices, that is the best answer in this case. It is not given in the choices. Therefore, you have to pick one of these answers. Now, other than tracheostomy, to establish an emergency airway, the only thing that we can use is a cricothyroid membrane. Cricothyroid membrane is used, and this is called cricothyroidotomy. The process is called cricothyroidotomy, also called mini tracheostomy. Right. So this is your correct answer, and rest of them are not used for establishing an airway. Never. That means if somebody needs an emergency airway, the easiest and the simplest thing you can do is endotracheal tube. This is the simplest. Immediately, it takes just a few seconds to do it, and endotracheal tube are always present in the emergency ward, no problem. It's a non-invasive technique. You are not giving any incision, you are not doing any surgery, and so it's preferred. But like I said, this can either be passed from the mouth or from the nose. Either from the mouth you have to pass the tube, or from the nose. So if this area is, that's why the mouth cannot be open is given there, and the maxillofacial trauma, that means the nose and the maxilla is also gone. That means it is telling you we are not able to do endotracheal intubation. The next thing, if this is not possible, is do tracheostomy, a proper tracheostomy. It's called emergency tracheostomy, which is done in tracheal rings 2 and 3, like I told you. And if this is also not possible, then we do cricothyroidotomy in that sequence. Okay. So that's why I told you, in this particular case, if tracheal rings is given in the choices, that would have been the best answer. But since tracheal ring is not given in the choices, then you have to go for cricothyroidotomy, which is given in the choices. So keep in mind, tracheostomy is preferred over cricothyroidotomy always. Okay, cricothyroidotomy has many complications or side effects in future, so we try and avoid that. Compared to tracheostomy, which is more complications, more side effects. That's why we don't prefer to do it. And this is the image showing you how a cricothyroidotomy is done. So you can see that between this thyroid cartilage and the cricoid cartilage, we make an incision, and through that gap we put a tube, which is shown in the next image. Cricothyroidotomy, also called mini tracheostomy. Now in mini tracheostomy, cricothyroidotomy, this image is very important. That's why I'm showing you the image. They often give you the image based question. Again, it's a spot diagnosis. They'll give you this particular image, a similar image, and they'll ask you what is the procedure called, what procedure is being done in this patient. Straightforward question. Cricothyroidotomy, mini tracheostomy. So please remember this, guys. Simple, very important question. Okay. Then we go to next one. Which of the following is associated with CSF otorrhea? So CSF otorrhea means CSF flow through the ear. Don't confuse with CSF rhinorrhea. CSF rhinorrhea is a very popular topic. The CSF comes from the nose, and it's a very common disease also, common situation also we encounter in our clinical practice. And that's why they ask you question from CSF rhinorrhea pretty commonly. But CSF otorrhea is less common, and we do not encounter this problem very often in the OPDs in our clinical practice in ENT. That is a question from CSF otorrhea is less commonly asked. Now CSF otorrhea is due to fracture of petrous bone. Okay, fracture of petrous bone. Now petrous, what is the word petrous mean? The word petrous means rock. Patthar. So because this bone is rock hard, it's a very hard bone. So that's why the name is petrous bone. In some books, it is called the toughest bone in the human body. Some books will tell you petrous bone is the hardest bone in the human body. So it's very difficult to fracture this bone. That's why CSF otorrhea, I told you CSF otorrhea is less commonly encountered in the clinical practice. Why? Because fracture of the petrous bone will cause CSF otorrhea usually, and that is not common because it's a very hard bone. So the impact has been too much. Petrous bone will fracture only in the trauma is too much in this area, this temporal bone. Petrous bone is a part of temporal bone. So you can also call it temporal bone fracture. It's nearly the same thing. Petrous bone is a part of temporal bone. So temporal bone fracture and petrous bone fracture is common thing. So the question they're asking you is that which of the following is an association with CSF otorrhea? Battle sign, oral hematoma, hematoma in the ear, penetrating injury of the ear, of the eye, and fracture of the roof of the nose. Now petrous bone fracture is very commonly associated with battle sign. Here too, battle sign is always suggestive of an underlying temporal bone fracture. Battle sign is suggestive of underlying petrous bone fracture. So battle sign is a correct answer A. And this is the image showing you what a battle sign means. So this skin on this area, this skin which is the mastoid skin, becomes, as you can see, bluish in color. Because of the trauma, there is a trauma or damage of emissary veins. The veins in this area which is carrying the blood from the skin deep inside in the jugular vein are called emissary veins, and they get damaged and the blood will leak. So venous blood is leaking out. And what is the color of the venous blood? Bluish in color. So the skin becomes bluish because of the venous blood leak. So remember that battle sign is highly suggestive of underlying temporal bone fracture. So although because they fracture of the temporal bone, hematoma of the ear or the pinna can also happen. It's possible in this area, but because the skin on the pinna is very tightly adherent to the underlying cartilage, so hematoma of the pinna is very uncommon thing, because the skin on the pinna is very tightly adherent to the underlying cartilage, but can happen. But these two are very far away from the ear, so obviously they are not always associated with these two, but they can all happen. So why I came back to this paper, this particular slide, that in CS of otorrhea, which is suggesting a trauma and fracture of the petrous bone or temporal bone, everything, all this can happen, but it is association is with battle sign. So these kind of questions can sometimes be confusing to us. Okay, then question number 18. A patient presented with unilateral nasal obstruction associated with watery nasal discharge and bleeding. A diagnosis of inverted papilloma is made. Which of the following is true about this condition? See, such questions, now this is not a very long question, but this line is not unnecessary line. If you only read that we are discussing with inverted papilloma, and which of the following is true about inverted papilloma, isn't it? That's the question. So in this one extra line, which was not useful, but sometimes they can give you a long history. A question which reads 4 or 5 lines are there, you are reading them, and it is useless history. Only the last line is the actual line that will tell you the actual question. So that's why sometimes we suggest that always read the last line first. Sometimes it will save a lot of time, that you know straight away know they are talking about inverted papilloma, and inverted papilloma, for those who know, is the most common benign tumor of nose with malignant potential. That means it can get converted into malignancy. So benign, it's described as a benign tumor with malignant potential. It's not a malignancy in the beginning, it may become malignant. It's like a pre-malignant disease. The other name for inverted papilloma is Ringer's tumor. This question was asked sometimes back. What is a Ringer's tumor also called? This was MCQ. Ringer's tumor is also called inverted papilloma. So it's not a malignancy. So this two out. It's a benign tumor with malignant potential, means invasive. Malignancies are invasive in nature. So this becomes your correct answer. So benign tumor which is invasive like a malignancy. Okay, so these are the points about inverted papilloma that is important. The only other important thing about inverted papilloma may be about treatment. Now there are two things you can say. You can say excision with wide margin. When we excise the tumor, we take a margin of how much? 1 to 2 centimeter around the tumor. The same treatment can also be called medial maxillectomy. Okay. So far you must have realized, guys and girls, that questions from ENT are not very difficult questions that they ask you in your MCI screening test. And these are all questions from I have not made these questions. These are questions that have been asked in the exam. We are discussing past year's questions, isn't it? And if you have attended the ENT lecture in the classroom or on the app, you will realize that all these questions are from the class notes, from the app notes. So that's why we all tell you that read your class notes very nicely, revise them, repeat multiple times, solve some MCQs, especially the past year's questions, and that should take care of your thing. So don't stress too much. Exam is very close by. So just relax and just read the class notes and revise the class notes multiple times. And I'm pretty sure that you will do very well. Now this is another topic that they've been asking questions pretty regularly. A 35-year-old woman takes aspirin for headache, later presented with wheezing and breathlessness, bronchitis kind of a thing, or maybe asthma also. Along with these two symptoms, what other clinical features are likely to be there? We know that if they talk about the patient begins to have problem after aspirin, that the patient begins to have wheezing and breathlessness, that means the patient is sensitive to aspirin. And who are sensitive to aspirin? Patient with Samter's triad. So this question is about Samter's triad. And what are the three features of Samter's triad? Triad means three features. What are the three features? One will be aspirin sensitivity. which is given in the question. Second is asthma. That's why the patient is having wheezing and bronchitis kind of a thing, breathlessness. And the third is nasal polyps. Isn't it? So two are given. Patient is aspirin sensitive and the patient is having asthma-like symptoms. So nasal polyp is the third. So which is a likely clinical presentation? Nasal polyp. Now, although in Semter's triad the patient has sensitivity to the aspirin and the patient begins to asthma-like symptom, but it is not an allergic symptom. It's not an allergic disease. There is no allergy in this, and that's why it is not IgE. There is no IgE release in this patient. Okay, and it's not an extrinsic asthma; it's an intrinsic asthma, and there is no drug interaction. There is no interaction between two drugs. The patient is sensitive to drugs, not only aspirin, other COX-1 inhibitors. All other COX-1 inhibitors like brufen and other drugs, the patient is sensitive to all those drugs in this case. Okay. Now, along with Semter's triad, there are two more symptoms that are related to nasal polyps. So this is what they asked question twice in the last few years. Polyp, asthma, aspirin sensitive that we have discussed. But just remember, two more syndromes possible in nasal polyps. There is a polyp here, polyp here. So it can be seen in cardiac syndrome. In cardiac syndrome, there is bronchiectasis as well as situs inversus. And in Young syndrome, two are same. Polyp and bronchiectasis are same as here and here. But the third one is different, which is not situs inversus but agiosperm. Right. Now in Semter's triad, which is the most popular out of the three, the most commonly asked out of the three. Now in Semter's triad, like I told you, the patient is sensitive to aspirin, other COX-1 inhibitors. Okay. So what does this do? It causes dysregulation of the arachidonic acid metabolic pathway. This pathway gets dearranged, disturbed, and as a result, two things happen. The prostaglandins E2 will decrease and the leukotrienes E4 will increase, overproduction. So this increases and this decreases. As a result, especially because of prostaglandins, there is chronic inflammatory condition of the respiratory tract. That's why there is wheezing and all that. And this causes bronchoconstriction. Bronchoconstriction happens, and that is the reason for that wheezing and breathlessness, bronchoconstriction. Okay, so these are the points about Semter's triad that you have to know. I've given you additional information about the Semter's triad because recently they've been asking questions from this particular syndrome very commonly. So these are the additional points that you should know about this particular disease. Okay, nice. So let's go to the next question, which is question number 20. A 35-year-old woman presented to the clinic with symptoms of hearing loss and pulsatile tinnitus. Now, if you hear pulsatile tinnitus, straightway there is only one popular disease that causes pulsatile tinnitus. Now, this is not the only disease that causes pulsatile tinnitus. The most popular disease that causes pulsatile tinnitus is glomus tumor. So, if I read this one line, I know that it must be glomus tumor. But read the question, rest of it. Further examination reveals conductive hearing loss, and which means it is a middle ear disease, and conductive hearing loss will have negative readiness, which is gone, and a reddish mass behind the tympanic membrane. Because glomus tumor is a vascular tumor of middle ear, not always, but for our sake we can say. So that's why it's a reddish in color. So everything is telling you it has to be a glomus tumor only and nothing else. In AS, acute otitis media, there's pain, there's fever, there's hearing loss, negative readiness, all that is true, but there is no pulsatile tinnitus and there is no red mass. There is no red mass. The tympanic membrane becomes red. The TM is red, but there is no mass in the middle ear which is red. Okay, in this case. Chronic otitis media will have tympanic membrane perforation, always. You cannot make a diagnosis of chronic otitis media without a perforation, usually. Not 100%, but usually. Okay. So there is no mention of perforation and there is no pulsatile tinnitus in any of them. And serous otitis media, I told you about this before also in one of the questions. that only hearing loss is the symptom, and it is seen in children, small children, not in adults usually, more commonly, and it's blue to yellow membrane. Blue to yellow color fluid and discharge is seen. It is not red mass behind the tympanic membrane. So this very typical presentation is very commonly seen in glomus tumor only out of all the disease. In all of them, I've told you all the other important features. But in glomus tumor, you have to know 2 or 3 other points. It belongs to a group of tumors called paraganglioma. Remember this, they ask you that what type of tumor is a glomus tumor? Paraganglioma. Presentation is already given: hearing loss and pulsatile tinnitus, and there are 4 signs. I'll just give you the name of 4 signs. I think you know the names: rising sun sign, then there's brown sign, there's Phelps sign, and there's Aquino sign. Okay, so these are the other features of glomus tumor that might be important. These names can be important. They ask these names once in a while, so just keep in mind. But it's an important topic. Please read glomus tumor. Now, next question, question number 21. During a routine health check at a nearby school, you encounter a child who is experiencing delay in speech development. Okay. Upon examination of the ear using an otoscope, an image provided displays his appearance. So you can look at the tympanic membrane. Subsequent audiological test reveals hearing loss of 30 decibel. Normal is 25, so it's more than 25 decibel, so there is a hearing loss. So what could be the diagnosis? Now what you see is a red membrane with a pimple like thing in the center. This is called cartwheel appearance. This finding is described as cartwheel appearance. And cartwheel appearance with red tympanic membrane is a feature of acute suppurative otitis media. So straight away, this has to be AS. Very typical presentation and the look of the tympanic membrane. In serous otitis media, like I told you, it's blue to yellow membrane, and there may be retraction of tympanic membrane, and there may be air bubbles also, none of which is seen in this particular image. I told you in the last question that in CSUM, usually in most cases there is a tympanic membrane perforation, and there is no perforation in this case. And CSUM is more common in adults, can be seen in children also, but it's more common in adults, not so much in children. And glomus tumor has pulsatile tinnitus. We just discussed glomus tumor, pulsatile tinnitus, and those 4 signs: rising sun sign, brown sign, Phelps sign, and all that we discussed in this. So since we have done a similar question, similar choices with a different question just before this, so this question becomes very, very easy for you. Okay. A 60-year-old male presented with painless cervical lymphadenopathy. Then on examination, the right ear reveals conductive hearing loss with dull tympanic membrane. Now, dull tympanic membrane is another term which is used for retracted tympanic. And I just told you, retracted tympanic membrane means serous otitis media. I just told you. So this patient is an adult. I told you serous otitis media is more commonly seen in children, but this is an adult with serous otitis media. If an adult has serous otitis media, one of a very important thing that you have to rule out, what? Carcinoma of nasopharynx. In every adult with unilateral serous otitis media, you should rule out nasopharyngeal carcinoma. What is the most common presentation in nasopharyngeal carcinoma? Most common presentation in nasopharyngeal carcinoma is cervical lymphadenopathy. It's a very popular MCQ. What is the most common presentation is nasopharyngeal carcinoma, cervical lymphadenopathy. And in this case, the patient has cervical lymphadenopathy. A patient with cervical lymphadenopathy, adult with cervical lymphadenopathy and serous otitis media is most likely having a nasopharyngeal carcinoma. Moreover, this mobility of the soft palate is also decreased. Now, in nasopharyngeal carcinoma, some patients have what is called tortoise triad. They begin to have tortoise triad. There are three features in this triad where there is a hearing loss, which is given in this patient. There is soft palate palsy, where the palate movement is gone, which is also given here. And the third patient is pain. So pain is not given in this question, but this tells you that this is, don't think painless lymph nodes are not pain. In tortoise triad, this pain is facial pain. Pain on the face, not on the lymph node. So don't say this is painless, so pain is not there. This pain is talking about the pain on the facial skin, not about lymph node. So lymph nodes are usually painless in this patient. So this patient is perhaps having tortoise triad also. So they are asking you what is the probable diagnosis. Obviously nasopharyngeal carcinoma. Everything is telling you this is nasopharyngeal carcinoma with tortoise triad, right? Okay. Remember, angiofibroma is seen in children. A child, male child with bleed. There is no mention of age is not matching. The bleeding is not given. Quinsy is peritonsillar abscess. Peritonsillar abscess. So it has no glue ear, no hearing loss, and the pain is inside the mouth. Not there is no lymph node in quinsy. Lymphadenopathy. Cervical lymphadenopathy may be seen, but not too much. So this is clear-cut a case of nasopharyngeal carcinoma. So again, nasopharyngeal carcinoma comes into play. We have one more question related to nasopharyngeal carcinoma. So nasopharyngeal carcinoma is a very, very important topic in your exam. You know that just before COVID, 4 times, 2017, 2018, 2019 and 2020 also, 4 times back to back in your question paper, there was a question from nasopharyngeal carcinoma. Do you know this? They asked nasopharyngeal carcinoma topic 4 times back to back. And in one paper, one of these 4 papers, there are more than one question. In the same question paper, there are more than one question from this particular topic. So nasopharyngeal carcinoma is a very important topic. First, it's a very simple topic. But guys and girls, please read this topic very, very nicely. It's a very important topic for you. But we'll go to the next one. In which of the following condition is bone anchored hearing aid, which is called BAHA, used? Now, BAHA is used in 2 situations, either a child needing hearing aid or where air conduction cannot be used. Okay. So, sensory hearing loss has nothing to do with AC. It is mainly about BC. Acoustic neuroma is a tumor, is a disease of the 8th nerve. So again, BAHA is not useful in that case. So if the external ear has congenital aprasia, if the canal is blocked, then AC cannot enter from here. And usually this is a congenital disease. So it is seen in children, obviously, isn't it? Congenital disease means it is child. So this is the condition which is serving both these criteria. It is seen in children and the air conduction pathway is blocked. That's why bone anchored hearing aid is only used most commonly in this. Out of this condition, bone BAHA is most commonly used in this particular situation. Now this is how BAHA looks like. This is that bone anchored hearing aid, BAHA. And as the name tells, it's anchored to the mastoid bone. So this is the pinna. Behind the pinna, this is the mastoid bone. Onto the mastoid bone, this hearing aid is fixed with this part of the hearing aid called the screw of the hearing aid. So the screw of the hearing aid is permanently fixed onto the mastoid bone, and from here, this is the main processor which is converting the sound energy into the potential energy, and through this bone the sound goes directly to the cochlea. So bone anchored hearing aid is used when BC is okay. BC is normal, but only AC is affected, that too in a small child. This is what I told you. If AC is affected in a small child, then BAHA is the best thing. Okay. If it is SNHL or acoustic neuroma, in both these patients, BC is affected. And if the BC is affected, BAHA is not useful. Right? That's why C is the correct answer. A person presented to the OPD with complaints of rotatory vertigo. Remember, I told you about vertigo. Vertigo is mainly horizontal or vertical. And horizontal vertigo is seen due to the problem of the lateral horizontal semicircular canal. Vertical and rotatory vertigo both are seen due to problem of cerebellum, superior canal, and posterior canal. They can all cause rotatory and vertical vertigo. So which of the following condition can cause rotatory or vertical vertigo and nausea in the morning on change of position of the head? So this vertigo is only happening when the head position, the patient changes the head position, and this typically happens in BPPV. BPPV patient has only one symptom. What is the only symptom? Only vertigo. There is no other symptom on changing the head position, and the vertigo in this case lasts less than 20 seconds. It's momentary vertigo, very short duration vertigo. Now vestibular neuronitis, which means inflammation of the vestibular nerve. Now this patient also has only vertigo but for days to weeks. It can last for few days to even 1 week, and it's usually seen, and it has nothing to do with head position. It is a continuous non-stop vertigo. It's a continuous vertigo. So unlike BPPV, the vertigo only happens when the patient is changing the head, otherwise there is no, if the patient is not turning the head, the patient will be normal. But in vestibular neuronitis, whether the patient is turning on the head or not, whether the patient is lying or sitting or walking or standing, there is non-stop vertigo, continuous vertigo. So it cannot be vestibular neuronitis. In rest of the two conditions, that is labyrinthitis and Meniere's disease, they will also have vertigo. They may have vertigo with sensory neural hearing loss. This patient may also have vertigo with sensory neural hearing loss, but in both these cases, changing the head position has nothing to do with vertigo. So the only condition out of the four which has vertigo, which happens only when the patient is changing the head, is BPPV. So BPPV has vertigo for less than 20 seconds, happens when the patient is changing the head position, and there are two maneuvers they ask you about BPPV, which is a very popular maneuver. One is called Dix-Hallpike maneuver, and one is called Apley's maneuver. So remember, these two maneuvers are the most important names that they ask you in BPPV usually. Besides these two maneuvers, the only other question they can ask you is the type of question that we have discussed right now. So this is a very simple, important topic, BPPV. And then we took question number 25. Now, this is a very, very popular image. So this is the image they are asking you, that this marked area, you can see the red arrow. Which of the following diseases happen in this arrow? Now, this is an image of nasopharynx. Now, this is the first thing that you must be able to identify. In this particular case, there is no hint to suggest that it is nasopharynx. You only have to identify by looking at the image. Often when they give you the image of the nasopharynx, they will tell you this is the image during nasopharyngoscopy. So when they say this is the image of nasopharyngoscopy, the name is telling you it is nasopharynx, isn't it? And in nasopharyngoscopy, when you should look at the nasopharynx, you should be able to identify this thing, which is the station tube opening. And the other important thing that they have asked is this area which they are asking is called fossa of Rosenmuller. Behind the station tube is fossa of Rosenmuller. It's a very important name, Fossa of Rosenmuller, and it's a very important image also, where you should be able to identify the Fossa of Rosenmuller. Now, why is Fossa of Rosenmuller in the nasopharynx behind the station tube important? Because it's the most common site of nasopharyngeal carcinoma. So which disease happens here? Nasopharyngeal carcinoma. Straightforward. That's why I told you nasopharyngeal carcinoma is very important. They've been asking this question so many times, and we have discussed 2 or 3 questions related to nasopharyngeal carcinoma because of the same reason. It's very important. Angiofibroma arises in sphenopalatine foramen, not in sphenopalatine foramen. Okay. Antroconal polyp, remember, is a maxillary polyp. So maxillary polyp, it comes on the maxilla and goes towards the nasopharynx, towards the quena. It is nothing to do with the nasopharynx. And inverted papilloma is seen in middle meatus of the nose. Most commonly, it is seen in middle meatus in the nose. It's nose, not nasopharynx. Okay. So these last 3rd and 4th diseases are related to nose and sinuses. The first 2 are related to nasopharynx by and large, but nasopharyngeal carcinoma seen in Fossa of Rosenmuller, which is shown in the image, but angiofibroma seen in sphenopalatine foramen, and we have discussed questions on angiofibroma already, right? So these are the 25 questions that I wanted to discuss, because I was told that we should complete by and large. We don't take too much of time of your best available time. We want to complete the discussion within 1.5 hours. So I've done that. So I hope that this session was useful and we have been able to cover the type of question that they ask you. More important than the question, the topics that they ask you: nasopharyngeal angiofibroma, carcinoma, glue ear, serous otitis media, different types of otitis media, rhinitis, sinusitis, and such questions they've been asking in the exam very commonly. So it was pleasure teaching you guys and girls. I hope this was useful. Please work very hard for your exam, because we all want to see you come out with 5 colors, so that next year we can again engage with you for PG entrance exam, NEET PG. We can discuss together for NEET PG and prepare for that. Okay, with that, I take a leave from you. Once again, best of luck. Take a very good care of yourselves. Bye guys.